Hello, everyone. Welcome, and thank you for joining the 26th webinar in our Pandemics and Society series. Today's webinar topic is Toward Cleaner Indoor Air, Public Health, Prevention, and Resilience. I'll now pass it to our moderator, Jennifer Nuzzo, the director of the Pandemic Center and a professor of epidemiology at the Brown University School of Public Health. Jennifer?
Hello, all. Welcome to our discussion today. So we're going to talk about the health impacts of indoor air. And if you've been following along, became an important topic during the COVID-19 pandemic, and it remains an important consideration for talking about the spread of infectious diseases. But infectious diseases are not the only health concern that have been tied to indoor air. There are other health issues that have also been flagged, cognition and asthma, a variety of other health impacts. And so we want to have a kind of fulsome conversation about all of this. This is a very timely conversation across the US and elsewhere. Schools are starting again. We know that this is an important issue for kids and schools. An estimated 5 million children in the US have asthma, which causes millions of missed school days each year. And we know that indoor air quality may play a role there. So we want to talk about that. We have also across the summer, throughout the summer and different parts, seen once again the impact of wildfires. And so we for the communities that are living near those wildfires or downwind of those wildfires, they have witnessed quite visibly and have felt the threat that the smoke poses to public health. What may be less obvious is the fact that the majority of the exposure to that smoke likely happen indoors. So lots of ways that indoor air can affect our health. And given this, what are the practical steps we can take in order to make improvements on this front? So we're going to talk about today. We are fortunate to be joined by 4 top experts on this topic. I'd like to first welcome Dr. Mark Hernandez, who is professor of environmental engineering at the University of Colorado Boulder. Mark's been working for multiple decades in doing pioneering research on the connection between indoor air quality and reducing exposure to disease transmission and indoor pollutants. He's doing work in partnership with the Colorado Department of Public Health around air quality interventions in classrooms, and I hope we can hear about that. I'd also like to introduce Mr. Kenneth Mendez, who is the CEO and president of the Asthma and Allergy Foundation of America. Since joining the foundation in 2018, he's led national advocacy efforts for better indoor air and reducing the impact of asthma and allergies on underserved communities. He's been a major voice for the patient advocacy community and has supported the development of several state and national policies to address asthma. And I'm also going to welcome Dr. Jacob Sweat, who's the executive director and founder of Blueprint Biosecurity, which is a nonprofit that's dedicated to achieving breakthroughs in humanity's ability to suppress pathogens. Jake's been a leading voice in the biosecurity community and was a major contributor to the Apollo program for biodefense, which was a report published in the wake of COVID-19 from the Bipartisan Commission on Biodefense. And then, last but not least, is our own Dr. Georgia Lagoudas, who is senior fellow here at the Pandemic Center. She leads for us the Clean Indoor Air Initiative. She's been working for a long time to advance policy and implementation for indoor air quality standards, both here in the United States and internationally. She came to the Pandemic Center from her previous role working at the White House in the Office of Science and Technology Policy, where she also tackled issues around indoor air quality, including having hosted the White House Summit on Clean Indoor Air. So thank you all for joining us. We've got a lot to get into and really an embarrassment of riches in terms of expertise here. So I want to just jump right in. We're going to start the conversation with just some questions to you all. And then at some point we will turn to the audience for Q&A. I believe there's a Q&A box that audience members can feel free to use at any point. But I'm going to take moderator's prerogative and just start first. And maybe first I can turn to you, Mark. I'd love to hear more about the work that you're doing in Colorado, particularly around schools. I understand you're doing some kind of interventional studies, and I'd love to hear more about that, including if you're able to offer any insights that you've learned so far in that work.
So if I were to give you the thumbnail history, of course, the major effort started by philanthropy during the pandemic was the first semester when kids came back to school. And they were the little kids. Elementary came back first. They were the last to get vaccinated and the first to return. That was spring semester of 21. And by then, the chatter of airborne transmission, concerns about classroom transmission were peaking. And our pilot was by putting donated high efficiency particle filters in the classrooms, elementary school classrooms, before those kids came back. And I have one prop behind me, which is an actual HEPA filter. Essentially, they're a filter and a fan. The major concerns were interruption with the educational environment, noise, electricity in the classroom, things the kids weren't getting used to, or weren't used to, or parents weren't used to, or administrators weren't used to. But we got permission, got them in there, and we, using high quality monitors, measured what the kids were breathing in classrooms with and without these. So we were able to show that this really knocks down the microscopic particle loads of what kids are in the classroom for a very small amount of money, essentially the cost of a textbook. And prior to that, I think that there was misconceptions about the cost of simple interventions for that. We tried it, costed it out, and then with the help of CDC and our Colorado Department of Public Health, went statewide. So right now we have 70,000 of these purchased, 35,000 classrooms have them, and many of those classrooms are coupled with affordable air quality monitors to show that they work. And I liken those, and you named all the bad stuff beyond COVID and flu, allergy triggers, wildfire smoke, construction dust, all that stuff, especially in older buildings, can penetrate and cause exposures. So I call these seatbelt for lungs. There's no reason why we shouldn't use them at the cost points that they are right now. And the other take-home point we learned is you can't manage it if you don't monitor it. So like a dashboard for a car that's telling you the function of your vehicle, we should have a dashboard for our buildings that tells us what we're breathing. It's cheap, affordable technology now. And we're demonstrating that in about 6,000 classrooms. So slowly but surely, we're making progress from a pilot of 20 to now statewide.
Wow, it's really incredible. And thank you for bringing up flu. I do want to talk about that. This has been one of the worst years for flu in kids since the United States started actually keeping track. So I want to talk about that. But maybe first, before we get into that, maybe I'll turn to you, Kenny. I'm sure people who are tuning into this Pandemic Center webinar may be a little bit more familiar with the relationship between indoor air and infectious disease, but you're focused on asthma and allergies. So I'd love to hear from you. Why is indoor air important for asthma and allergies?
Yeah, well, thanks for inviting me. For the audience, I'm not an expert in this, but it's really the patient voice and try and give a voice to what we experience. For the 28 million Americans with asthma, and what a lot of people don't realize is that close to between 9 and 10 people can die each day from asthma. So it's something that you really need to control. And indoor air is really important. We spend 90% of our time indoors, and the triggers indoors can generate an asthma attack, and it's really important to be able to control that. And then, per what Mark was saying, just in schools, if you think about it, it's the number one reason for missed school days, or a top reason for missed school days. So that's why it's really important to have clean air in schools. That's where the kids go to work. And the other fun fact here, or not so fun fact, is as we approach back to school season, there's something called peak week, which comes in the later part of September. Usually it's been the third week in September. And that's because kids are coming back to school, adults are in the classroom as well, they're teachers. And then so you've got the fall allergy season, which is primarily ragweed. So you've got respiratory things going on there, plus viruses spreading in the classroom, and then that spreads to the general population. But what we see in peak week is a spike in emergency room visits and hospitalizations from asthma. So if there's anything you need to know now is like be prepared for peak week, have an asthma action plan if your kid's going to school, understand what your triggers are, and make sure you have clean indoor air to the extent that you can inside your home and in your classroom.
Yeah, that's really some stunning statistics there. Jake, maybe turn to you. You're focused on sort of the next big threat, not just the next pandemic, but it might not be a naturally occurring event. It might be a deliberate event. Why are you thinking about indoor air? What does it mean? I know people have thought about in the context of COVID, but they may think COVID, that's behind us. Why do I need to worry going forward?
Yeah, it's a great question. I think for us, we really see indoor air as the first line of defense. If we step back and look at the big picture of biological threats and pandemics generally, there's lots of ways that pathogens spread. And to some extent, I think we have a little bit of a success story here. It's not a complete story. It's not one that's finished. But largely what killed us previously isn't what the threat is today. If you look at foodborne, waterborne, and vector-borne threats, now tragically, this isn't true globally. But when we think about tools in the toolbox, for a handful of these, we actually have quite a bit. But if you look at what we're really most vulnerable to, it's respiratory pathogens. And there's some really fascinating history here about why the sanitary revolution went on the way that it did and what we ended up being protected against and whatnot. But that's where we are now. And then we also have this kind of unfortunate situation as well, where when we think about what are the kind of characteristics of a pathogen that's most likely to cause a pandemic, it's also likely to be respiratory. The Johns Hopkins Center for Health Security has a really great report on this. And so we're kind of in this situation where we have actually a lot of tools and resilience broadly against infectious disease, which makes us confident to drink water and not have a threat of cholera, or eat our food and not have largely risks of an infectious disease. But in the area where we have these pandemic threats, we're quite vulnerable. And so, and I think a lot of people know this, but we also are really concerned because we have that dual situation, and then the likelihood of another pandemic is not low. The Center for Global Development estimates a annual likelihood of a pandemic of 2 to 3%, which is something around a 50% probability in the next 25 years. And so that's what's really motivated us as an organization. Of this threat is imminent, and it's most likely to be airborne, and we don't have a lot of resilience here. And so we think there's a lot to be said about putting more tools in the toolbox. We see none of this as an either or when we're thinking about other types of countermeasures. But stopping an outbreak from becoming a pandemic is possible. That's something we have a conviction of as an organization. But it's hard. It's extremely hard. And so we need as many tools in our toolbox as we can get. And so we're really excited about filling that toolbox with the kinds of capabilities that give us that clean air. And not only is it a gap, but we think that there are ways that can complement the broader set of tools that we use to address pathogens. Even ambitious goals like 100 days for a vaccine is a long time with the pace of that some pathogens spread. I'm incredibly excited, and I think we should be investing more in broad spectrum antivirals and vaccines, but we haven't quite seen those deliver yet. We have trends of antibiotic resistance growing, and we think respirators are an important tool here. It's something actually our organization spends a lot of time working on, but we're aware that it's also kind of the equivalent of boiling water at our source. And so we're very motivated by looking historically and thinking, how do we get the air we breathe to be as clean as the water we drink? And thinking about the resilience that comes along with that, whether it's our resilience against cholera in the United States right now, or the fact that it has some deterrence by denial, even in terms of that capabilities. And so for all those reasons, we're really excited about it. And I think collectively is why we really see this in many senses actually as the frontline defense against pandemics, because of this factor of them most likely being airborne pathogens.
Yeah, thank you for that. And one of the things that we at the Pandemic Center are constantly trying to educate around is that just because COVID's over doesn't mean that there's not going to be a next pandemic. There's going to be another pandemic. There have been 5 in the last 100 years, 5 pandemics in the last 100 years. So that's a pretty regular occurrence. And there's a lot of reasons why we think they're going to happen more. There's also the possibility that the next big one may not be it could be worse than COVID, and it could be deliberate. It could be caused deliberately. So, why we're interested in this space of indoor air quality is it's the thing that's operating in the background that you don't have to think about, that keeps us safe, just like our fire alarms and other things like that. So on that note, Georgia, you were at the White House and you led national kind of policy efforts around this, sort of like, what are the steps that we can take? Like, what are the policy initiatives we can, first of all, what has been done? And then what else can be done? Recognizing that maybe the momentum and will isn't the same as it was as it was 5 years ago, when people were deeply scared of these pathogens because they saw it happening in front of them.
Yeah, thanks for that question, Jen. And it's great to layer on to great comments from Jake and Mark and Kenny. To add in, I think my camera's frozen, but hopefully it comes back.
We can hear you, so just
okay,
keep talking.
Keep talking. I'll start by saying what you said, Jen, that this is an important piece that can help us for now and many years into the future. It's this piece of resilience, right? Of thinking about how we make buildings where we spend 90% of our time generally more resilient. And that's both to asthma, as Kenny mentioned, to potential future pandemics, as Jake mentioned, to student cognition and test scores and presence, as Mark talked about, and broadly to us, how we feel and how we think every day. And just like my quick story of how I approached this was at the White House as the pandemic was unfolding. And we talked a lot about many of my colleagues there were talking a lot about countermeasures and vaccine development, therapeutics, but we took a little time to arrive at clean indoor air as a tool that can have broader resilience across all these threats. And it's passive, it's in the background. You walk into a building, you don't have to think about it. And in some ways, right, we expect clean air, clean water to flow out of our taps. We turn on the faucet and clean water comes out. And we don't yet have an expectation, but we should, that clean air should flow out of the vents in our buildings. And the other piece that I'll add is that it's simple. There's a number of advanced technologies that we can do to advance air further, but Mark has something behind him that is a filter with a fan, and you have an electric plug that you plug in the wall. And really that's what clean air is about, that we're talking here, is how do we move air through filters to get rid of virus pathogens or bring in fresh air from outdoors when it's clean and fresh. So what happened before in the early stages of the pandemic at the White House was catalyzing some action where there was momentum to say, yes, let's take action. And so we took advantage of that. And there were three main steps that the federal government took. One was the CDC came out clearly with guidance for the first time ever outside of healthcare settings. These are recommendations to aim for 5 air changes per hour in all buildings across America. Number two, the government led by example. So they said government-owned buildings under the General Services Administration, where we will launch a ventilation verification program to check the ventilation in our buildings. Most buildings only check their ventilation once, or required to check their ventilation once, and that's when the building is built. Buildings last on average for 80 plus years. And then number three was kind of a more nuanced piece about this, but building codes play an important role. And so the White House we partnered with the Association of Ventilation Engineers that puts forward building codes for ventilation. And they put out the first ever health-based building code to help address reducing the spread of infectious disease. Those are all starting points. And Jen, as you identified, there is a lot more to go. And I think we have lost some momentum because the pandemic is in the backseat. And so I think there are also important reminders that we should remember that this is not just about virus and respiratory disease spread. This is about students coming back to school and not going home and getting sick or not spreading disease to their families, being able to be present and be learning. This is about minimizing impacts on asthma. This is about having resilience against wildfire smoke. And so the last thing I'll say, and happy to add more, but I think there's major opportunities for federal policymakers as well as state actions. We've had over a quarter of states pass legislation in the past 5 years on air quality, which is amazing. I think we can build on that progress. A lot of it is about schools. I think opportunities to improve air quality in schools, and importantly, just put someone in charge at the school district level or at the state level to think about air quality. It's something that often falls between the gaps. And then I think similarly at the federal, like I said before, opportunities to advance clean air in our own buildings and government buildings, opportunity to advance clean air with tax incentives, and then opportunity to help strengthen the evidence and make sure we have the research there.
That's great. Maybe to kind of build off of that a little bit, there've been, just it seems like one after another sort of look backs on COVID, and a lot of them in the lens of, we got it all wrong, and that thing that just killed upwards of 1 million Americans and, possibly up to 10 million people worldwide didn't really happen, or it wasn't so bad, a lot of like revisionism of what's happening. I guess one of the questions is sort of going forward from that, when we have some of those headwinds. At the same time, during that, we had this incredible intervention that was finally starting to get attention. I take the point that it didn't get as enough attention as early as it should have, but there at least was a national conversation about indoor air. Unlike controversial things like closing school and shutting down businesses, indoor air was something that, again, didn't require people to give up stuff. So why aren't we done yet with the job? Like, why? There was money, there was attention. Why? What do we need to do to move forward? Can we, given the moment, the kind of attempt to, write a new history of the last 5 years? I'd love to hear each of your thoughts on this. Just like, what are you thinking, given the kind of political realities we are in the moment, where there isn't the same kind of momentum, where there was a national conversation, there was money. Now, where does that leave us? And I'll take whoever wants to chime in on that first.
Can I just chime in on that, Jen?
Please.
Because I understand what you're saying, but I think there is still an opportunity here. I think
Yeah.
you have to find common ground, and the current administration is talking about making Americans healthier again, and they're also very concerned about kids in schools. And certainly, with all the cutbacks in the federal programs from Medicaid, for example, and the CDC and other areas, I mean, upstream interventions in order to solve some of these chronic health issues will be really important. And I believe that what we're talking about here in indoor air quality in buildings is critical in trying to find that common ground to show that you can actually make people healthier again by improving their indoor air without using medications, without spending a lot on hospitalizations or anything like that. So I think the work that you all are doing and the standards that you're setting here have to maybe be framed in we can make all Americans healthier again versus a look back at the pandemic, which is I understand and appreciate that's where all you're coming from, but really what's ahead and what are the costs? I mean, asthma costs the economy $82 billion in hospitalizations, emergency room visits, and missed school days and work days. So how can we communicate now to the federal policymakers that making an investment in indoor air can help reduce costs to the healthcare system and improve outcomes for people while they're cutting back on some of these social programs?
Yeah, thank you for that. I think it's a nice way of framing these issues and an optimistic take on the possibility for common ground here. Mark, Jacob, Georgia, anybody want to add to that conversation?
I'm happy to jump in. I do like to think, I like to see it as we're making progress. I do think we saw a lot of this catalyzed by the pandemic, but if you think back to that statistic I shared earlier, and what you noted in terms of the likelihood of a pandemic, it's not clear we're making progress fast enough. And I do think one challenge here with indoor air, at least as it relates to an infectious disease, is that there's a little bit of like seeing the status quo as like not our problem, but having to do something so is seen as a cost. And there is a little bit of, I think, here a case where as society we're a bit resigned towards colds and the consequences of particulate matter. And some of this I think is really kind of fascinating historically, where actually the majority of history we thought everything was coming from the air in terms of miasma, and then when we had the germ theory of disease, there was a big pushback against it. When someone kind of said, "Hey, I think that's airborne," people were like, "No, like you idiot! Like that was miasma. Like we got rid of that." And it's still taking us a while to recover from that. And the motivation that we had to do the sanitary revolution was a very unfortunate motivation. It's where you know, a lot of your siblings didn't you know, grow up past the age of 1, and infectious disease was much more pervasive. And I think a little bit we're a victim of our success here against infectious disease, where we see much less consequences, and so we see much less motivation. But you know, as a community that's interested in doing something about that, you know, I see that a bit as on us to help different stakeholders see the value in these types of interventions and really make that clear to them. And so, you know, that value, I think, even needs to be translated down to what different stakeholders care about, whether that's, you know, students in a class or test scores, whether it's hospital-acquired infections. I mean, if you're a software company, is it the number of commits pushed, you know, whether it's the number of sick days used? If you're an Olympic team, the time on your quarter mile, because you know, what you've been reading. I mean, all those types of things, I think we can tie this back. And you know, what's obvious to us, you know, isn't necessarily obvious to others, but you know, we can invest in that and make it happen. And so I really think data is a really important part of this, and demonstrating the need for this. If there's questions about safety or whether there's other consequences, there's a little bit of a higher bar for evidence that we need to show. And I think there's also, you know, innovation that can be done too to help push this along. You know, if you put a portable air cleaner in a classroom and people just see it as a noise box you have to pay for that does nothing for you, like, of course you're going to unplug it. You know, that's not actually unreasonable. And so I think we have to, and I know Mark's work is doing a lot here to actually, you know, generate this. We have to kind of go to that next level. And whenever we're talking about these costs, whether it's like the actual cost of putting it in or the cost of a noise, see that in terms of a cost benefit equation and be helping people understand those benefits much, much more clearly as it really translates and matters to them.
And Mark, maybe I'm gonna cue you up for a second, because it's kind of, that was a natural natural turn to you, but talk about the benefits. And it's school starting. I know parts of the country it's already started. Here in Rhode Island, my kids are going back next week. Other people will be going back after Labor Day. Can you talk to us about some of the benefits?
Oh, benefits are easy. Costs are not, and Jacob queued me up that way. And I'm not a sociologist or a medical practitioner. I'm an engineer, and if you in our field, environmental engineering field, it's all about exposure reduction, whether it be water, dermal, or air. That's the cheapest source control. Kenny threw out a big number, and I kind of want to start with a big number, and it was Bs, double-digit Bs. What we're talking about to map back to cost benefit is fractions of that. I mean, we're out at 0.0001%. The cost of a textbook per kid per year. That's where we are. Give up a Starbucks coffee one day a month, and we can have some great monitoring and great protections. One of the things about working with schools is it's very primal, and parents appreciate it, teachers appreciate it. I don't think that there's anybody, or very few, right? Most people, most of the time, would be all over giving added protections and better educational environments to children, right? So that I think the sociology, what we're talking about, apart from cost benefit analysis, the heady stuff is human, you know, societal nature. So that part makes it easy. Proving the benefit is a little tougher. And you know, we're kind of ground level with that. When I put these things in the classroom, when they and operate them in a way that doesn't bother anybody, which can be done, especially with the new gen stuff, they're quiet, cheap, $8 a filter or something like that. Does that actually improve butts and seats? Really, that's what it comes down to. And schools are funded that way, at least in my part of the country. They literally count student days. So that's how we are funded, and I think many other big school districts, I know Boston being one of them, that's how they're funded. So anything that we can do to move the needle, you know, very affordably in something that's boiled down to a textbook cost, where schools are used to talking about these things, a cup of coffee, if we can normalize it, all of it without being heady and present that to our stakeholders, children, their parents, public at large, I think we can get there. But then again, I'm not a sociologist. I feed sociologists data. I feed epidemiologists data. When we operate these, do I get less absenteeism? It's almost that easy and we can disaggregate that into asthma, into infectious disease, tummy ache, whatever you want to do it, which is what we're doing here. The epidemiology is hard, but
Yeah.
without the data, we can't do it. And then what I want to close this question was what the monitoring offers us. And I have another prop. Georgia has a prop. We have good high quality monitors systemically. We can put them in classrooms or we can carry them. I do. My geek friends do. That say, what's the nature of the particulate matter I'm breathing, the microscopic stuff that we can't see, most of the time doesn't bother us. Sometimes it does make us sick. What's the CO2 level? Just basic stuff. We can get used to what's normal and what's not. And if we don't have the data, the dashboard, public facing information about what's the air quality in the schools that my children are in, what's the air quality of the transportation hub, the airport gate, the bus depot, the train, where we all don't have a choice about being. Kids must be in school. We have to travel for business and education. If we can get used to what's normal and not, just like we do with the dashboard of the car, it's not that hard. But we got to get the data in front of folks in a way that's digestible and affordable. So that's the engineering part of me talking. So I'll leave it there. Hopefully I answered your question.
Can I set up Georgia on this because we did, and this relates to what Mark was saying about cost, but we worked on the state-based advocacy bill, and I remember Georgia when you and I testified in the Senate committee, and you also testified in the House committee, and you pulled out your air monitor and you described what it did and how you read the room before it became packed with people and then afterwards. And I know a lot of you all understand that, but I think for our audience and the audience in the asthma community, it might be interesting to talk about that too. In addition, sorry, Jen, whatever else you were going to ask, but
No, please go ahead.
just so that people could understand what that monitor does, and maybe you could describe what happened there in terms of the room and what it means for people in a room.
Happy to, Kenny. Thanks for bringing that up. And it was a really, really cool opportunity to share with policymakers
Yes.
why this matters, right? And this connects everything that Mark and Jake and all of us are saying, that there is this concept that clean air matters, but what does it mean in practice? And maybe that's dollars or maybe that's health, but like to someone's bottom line, what it means. So Mark waved his air quality monitor. I have another one. This can give CO2 or particulate matter. I'm sitting in front of it and have closed my door. And so mine has actually gone up to 1,500 parts per million of CO2 in my small, not very well ventilated office at home. And Kenny was sharing when we were in the House committee room. So this is lawmakers from Rhode Island gathered, and we started, and the room was about 800 parts per million. And then as we packed that room with order of 60 people, this is an older building, this is the State House of Rhode Island, ventilation could not really keep up with the number of people in the room, and it crept up from about 800 to 2,000 parts per million of CO2. And what I shared there is when we reach about 2,000 parts per million, that means for every breath you breathe in, you're breathing about 4% of someone else's exhale breath. So we're sharing the same air. Air is this resource. And whether it's air, airborne pathogens or particles we're sharing or anything that's coming from the outside, that matters. That's important. Anyway, so that's deriving from Kenny's story. And I want to add another piece to think about how do we have durable change? Like, what does it mean? I think there's two components. One, Mark said, is you can't manage what you don't monitor. You can't manage what you don't measure. So if we don't have numbers, it's this invisible thing that floats around us and exists around us. But when we start by putting metrics to it, I think that's a really powerful movement. And also knowing what to aim for. So something we worked on in Rhode Island, and right now I have some partnerships with a few states, including California, Colorado, Connecticut, and others, as they're trying to develop targets. Like, what should schools and others aim for? We don't actually have a clear number. The Clean Air Act of the 1970s from EPA, they set numbers for outdoor air quality, but we don't actually have indoor air quality standards for the United States. So I think one is putting some numbers to it. And then the second that Jake and Mark brought up is this implementation. You might give someone a tool. You might give someone like that air quality portable air cleaner sitting behind Mark on his desk. But we found during COVID, we interviewed over 15 states that led statewide programs to deploy air quality monitors across schools. And many of those states purchased air purifiers, but many of those are now no longer used, or it's up to the teacher to turn it off, on and off every day, or it's sitting in the basement collecting dust, or someone doesn't know what it is or why it's useful. And so I think we need better both implementation measures and better technology that's easy to use and is fit for purpose for places like schools and nursing homes and other vulnerable settings.
Yeah, I mean, I know just feedback from I have school age kids from teachers that part of it is the sound, the loudness of the devices in their classrooms is why, and it's obviously a fixable problem. Cost around who pays for the replaced filters, etc. But these are all fixable, and maybe it's a good opportunity. I want to turn next to the Q&A, but just before that, actually no, this already came up in the Q&A box. Could maybe Georgia or Kenny talk about the legislation in Rhode Island, and would that, what is that aiming to do, and does that address some of these come to implementation issues?
Sure. Well, maybe I'll start and then you could go on, George. I mean, the idea was in Rhode Island, well, first from a big picture point of view, we started to think, what can we do in the states? There's the federal push, but there's also a state-based push. And we looked at Rhode Island, and from our statistics at AAFA, the Asthma and Allergy Foundation, we do rankings of the 100 largest cities and the ones that are most challenging to live in with asthma. And Providence always came up quite high. It was number 10 last year. Our report's coming out in September with the new statistics. So we thought, what can we do in Rhode Island and in schools in particular, since it's the top reason for missed school days? And Rhode Island, every number of years, I think it's every 5 years, has to look at their physical school plants and evaluate them. And so we thought this was an opportunity to basically bring an indoor air quality element to once they look at their actual buildings, how would it affect kids. AFA also publishes a state honor roll report where we rank all 50 states, and we have based on their policies in schools for asthma and allergies. So this all kind of worked well for us from a policy perspective. Then Georgia was on the ground in Rhode Island, and then also had the expertise since we met when she was at with the White House, and thought, well, what can we do in Rhode Island? And so this bill basically tries to establish an indoor air quality standard for the public school. And then along with that, it had the simple thing of trying to, when you're looking at the ventilation system, put a MERV 13 filter on there if you can, if the system can handle a MERV 13, because that's probably going to filter the most particulate matter. And you only have to do it once, just when you do it the first time. But there's never been any of that kind of evaluation of the physical plants in Rhode Island. That's what we were trying to do. But Georgie, you want to describe some more?
Sure. I can add on, and just to share, as Kenny outlined, there was a coalition that came together. So
Yeah.
as an Allergy Foundation, Brown University School of Public Health, the American Lung Association and the Rhode Island chapter, the Ventilation Engineering Association, some of the voices from the education community and others. So this is a broad, bipartisan, really foundational group that crosses multiple voices to come together. And so this group came together to say this topic is important. one of the senators from Rhode Island is a ventilation engineer, and he stood up in the hearing and said, I've done ventilation assessments in schools in Rhode Island, and we found scary stories of really bad ventilation systems that these kids are breathing every day. And so the bill, as Kenny outlined, did three main things. One, it says, let's put some voluntary guidelines up. What should schools aim for? How do we use these monitors to target a number that's healthy? Number two, let's upgrade to filters that actually capture the bad things in the air. So MERV 13 is a type of filter that captures up to 80% of airborne virus particles. MERV 8, a lower quality filter that it can be common in some buildings, captures 0% of airborne virus particles. And then number three, let's just check the ventilation in schools once every 5 years. And so this was built into the existing Rhode Island program of every 5 years to go out and do an infrastructure baseline. So to wrap up with the Rhode Island story, the bill passed unanimously out of the Senate, from the Senate floor. There was some continued discussion in the House, and so wasn't able to move through on the House, but we're really looking forward to the next legislative cycle, bringing that up and making sure all the right voices again come to the table to help move it, hopefully support it in a successful manner next year.
Yeah, I think, there's a couple of questions in the chat or comments. One of the issues we ran into on the House side, it did really well to get it through a new piece of legislation through the full Senate is pretty good. I mean, normally you have to take it to even get it voted on or considered or out of committee, and it must have been Georgia's health monitor, air monitor thing. But I think what we ran into was the cost issue, and the person who's actually head of the committee, the education committee in Rhode Island, was worried about the cost related to what this initiative might be. And we tried to tell them that there is no cost to it, or the cost is very minimal. And for what Mark was saying, a Starbucks card or whatever, I mean, the additional cost for a filter, MERV 13 filter, wasn't that much. And then Brown was offering to do the work in helping to establish the air quality standards. So, but it was a cost issue. Someone asked about how do we get principals to think about this, and I think we got to get the moms, we got to get the caregivers to really advocate for this on a local basis.
And dads.
And dads.
Yeah, okay. Turning also to the Q&A box. There's a question here about UVC, far UVC. Jacob, do you want to take that, or Mark? Anybody? It says far UVC has recently pushed. What are your thoughts? And then it raises some concerns about the potential harms.
I got a lot of experience testing for UVC, both in the lab and in the field. It works. That's for sure. There are a spectrum of things, cost, as always, but mapping back to both what Kenny and Jacob brought up is cost benefit, right? And degree of protection. It's a source control. It's the best thing you can do, right? I mean, not far UVC, but source control. We want it writ large before anybody gets sick. There's some emerging evidence that far UVC works on allergens because they're proteins, and far UVC denatures that. So beyond infectious disease, like a filter, it has multi-purpose. There are others in the air quality community that are concerned of what far UVC does to indoor air chemistry. And so there's, again, another cost benefit exposure analysis still to be done. And that's in the works. But it's used successfully in places with short-term exposure mitigation. Now we're talking about long-term exposure mitigation. And the guidelines out there are about UVC exposure to skin and eyes on adults, and children are not little adults. So I think the jury's still out. Can it work? Yes. Is it affordable? Yes, I guess based on what I just heard, it depends who you ask. Is it affordable or not? And if you do the math on it, far UVC, like almost any of the other engineering technologies that we're talking about, it comes down to you could make a textbook equivalent or coffee cup equivalent. We're not talking about building all new buildings for every school in the country. One last point I'll close with that prompt is monitors can tell us where the ventilation performance is the poorest and where mitigation measures, filters, far UVC, or whatever we do, we can prioritize it. It does not have to be in every classroom. And what we've learned from the Colorado Mountain West surveys of thousands of classrooms is we got a lot of great performing classrooms that meet the most modern guidelines. We don't have to do anything there. What we need to do is find out where the poor performing ones are and prioritize there. And you'd be surprised they don't actually map with building age. Sometimes they do, sometimes they don't. But again, if we don't monitoring is the cheapest thing we can do. We need to prioritize where we do our interventions. Monitoring can guide us to do that, where and when and how much UVC or filters.
There's another question about monitoring, but before we go to that, maybe Jacob, I just want to give you an opportunity if there's more you want to say about far UVC.
Yeah, I mean, maybe just briefly for people who aren't familiar, far UVC is a specific type of UV light. UV light, just like optical light, comes in different colors, and far UVC was chosen very specifically as a wavelength that is kind of intended to be safe by design, because the wavelength that they chose is the one where proteins have peak absorption. And basically because we're covered in dead skin, which is filled with proteins, what ends up being the case is that when they chose this wavelength is that all the things that you've heard about UV are true in terms of them damaging DNA and all of this. But since we're protected by this layer of skin, it means that we're safe from it, but everything happens to the pathogens. And so it is damaging to them and it does harm them. And there's a lot of emerging evidence that the safety here is strong. As an organization, we're funding more. We understand that if something has UV in the name, people are going to have questions, and there's a high bar of evidence that we'll want to generate to convince people. And all of this wraps into this broader conversation around people not perceiving this as a problem. And so this sounds like introducing another problem to them. And so, we see the bar on us to be able to really clearly demonstrate that safety. And so we're putting resources into that to understand and see what the evidence says there. And then also show the value to be able to demonstrate it. But so far, I think from the laboratory studies, the studies that have been done on humans, the fact that we probably have a decade of exposure for some people who were early adopters of this technology already, it's looking very promising. And as the data continues to come in, we'll know more. But back to my kind of point earlier, far UVC, portable air cleaners, even sometimes disinfection vapors and other types of capabilities. All of these are areas where we think it's exciting to be investing more in the research and studying them. Some will pan out, some won't, but it's clear that we need more tools in the toolbox. And so we're really excited to see more work go on in this space.
Thank you. Mark, there's a specific question addressed to you here. It says, how do schools manage data from their massive network of sensors? Who helps perform QA, QC, and validation? And what kinds of applications have the data beyond short-term checks of exceedances?
That sounds like 3 questions to me. So
Pick whichever one you want to answer.
perhaps I'll start with the manage one. So the data from the air quality monitors that both Georgia and I showed you are about counting the particles in the air we breathe, characterizing the gases, the most common one, CO2, in the air we breathe. And these monitors are real time. So like the dashboard of the car, you get real-time gas, oil pressure, temperature of the radiator system, and so on. You don't necessarily need to know how the motor operates to tell you what's normal and what's not. And we can compare those to guidelines. What these NGOs and data-driven organizations, as Georgia mentioned, an association of ventilation engineers and so on, there's a conglomerate, CDC, environmental engineers for buildings and so on, have put out different guidelines. So we can compare these numbers in real time to guidelines that are out there, or rely on, once you get used to seeing these numbers, you see outliers. So you don't have to know how the ventilation system works. What you do is you learn to recognize, hey, this is not a normal reading. Or if you want to dig a little deeper, compare it to the guidelines. So you don't have to be an engineer or a doctor or have some special training to get used to what's normal or not. What we need to do writ large, and I believe starting with schools is the best place, is get that monitoring system in. And again, forget the intervention, just the monitors are a half a cup of coffee or a half a textbook. They're very inexpensive. They're high quality. You don't manage the data, you watch the data. Boston, for example, has now you can log on and see any school, any classroom, what those numbers are at any time. Doesn't matter if you're a parent, who you are, you can go look. So there's no managing data, there's reading data and understanding what's normal or not.
Can I just ask a follow-up question about that? Like,
Sure.
what happens with that? Like, just,
What happens with?
I mean, so what then? So it's there. I mean, it's presumably you want to take action, right? You're not just monitoring to
I can tell you what the
Well,
superintendents and building
Yeah.
managers do in
Yeah.
the Mountain West. Again, recognizing something is not normal, the
Yeah.
facilities manager says, you know what, classroom 114 is not
Mhm.
operating the same as the other. Let's go take a look.
Yeah.
So it guides attention. When
Yeah.
Denver Public Schools, for instance, 207 buildings, more than 5,000 classrooms. Now every classroom has a monitor. Every one. It's like a smoke alarm, right? You don't notice it's there. The monitors now are very high quality, much like laptop computers, faster, better, cheaper, more reliable. And they're reporting in real time. So, a teacher could even say, hey, something's up today.
Yeah.
My CO2 is 2,000, and it's usually 1,000. So when you get eyes on these things and you get used to what's normal and what's not, it guides attention from facilities managers to do something, or to at least take a look that today's not normal on X. Just like my gas tank is low or the temperature of my car is extra high today. What's up? Maybe I better go see the mechanic. You don't have to be the mechanic. You have to be the watcher. And these things are quite easy to interpret or just get used to what's normal or not. That's what happens. At least that's what's happening here. It's bringing attention to outliers in terms of ventilation
Yeah.
performance, essentially. Is that helpful?
Yeah. Thank you. I mean, I think the follow-up piece is key.
Yeah.
There's a question here posed to anybody about we've been talking a lot about public spaces, buildings and schools and probably workplaces, but someone asked, what do we do at home? What do you recommend for home? What do you all do?
Yeah, maybe I could jump in. I was about to drop it in the chat. One of the things that we have is we have a healthier home checklist on our
Great.
website where you go through each room. You can mouse over it on our website. I'll drop it in the chat when we're done here, where you can figure out what the trigger might be. So, for example, in the bathroom, you always want to have a fan on after your shower and leave it on for a while. Open the windows because the moisture there can create mold. So mold underneath your cabinets, mold can be a trigger if you have asthma and allergies. That's just one example, but certainly having a HEPA air filter in your home is really important that can filter out some of the air. I mean, you all are the experts in some of this stuff. I think you want to get the right kind of HEPA air filter for you. We've got ones that we certify are asthma and allergy friendly, but I think the one thing you want to be careful of is having it throw off ozone, for example. You don't want to get an indoor air purifier that's throwing off ozone because that can be an irritant if you have asthma. So there are a lot of things that you could do to remediate some of the triggers in your home through an indoor air filter, and then also moisture and running fans inside.
And Maybe if I can add on, Kenny, to give an example of what I do at home and
Yeah.
what I do in my day-to-day life, as someone who thinks about this, maybe you might say lives and breathes this topic every day. I will often carry around a order of $100 air quality monitor. I can see at home what the quality is. I can see if I'm in an airplane and we're boarding and they don't have the ventilation on. I can see poor air quality there, or if I'm somewhere else, it can trigger me to take action or maybe put on a mask. And at home, in all of the rooms that I am commonly in, I have an air purifier on at all times, 24/7. I can do the math. This costs like order of a few dollars per month, if that, on my electricity bill for all of those 3 air quality monitors. Importantly, I have one in the room I sleep. I spend 8 hours in that room every day, and clean air there feels like a really important intervention. And then when I have people over at dinner parties, I will make sure, or events, I'll make sure that there's more ventilation and more filtration. So I think some of the layering on, in your day-to-day environment, how you can improve air quality, is a really important background measure that you turn on and never really have to think about it, and it can elevate your health, and reduce disease transmission.
I just want to add to what
Yep.
Georgia just said. And there was, in response to a prompt earlier, that when you have an intervention, whether it be UV light or a filter, that it's another appliance you have to pay attention to. Yeah. And we can normalize that. And Georgia gave a nice anecdote about normalizing that in her life. And teachers or facilities managers can normalize these. You got to turn the lights on. Why don't we do that with our
Yeah.
seatbelt for lungs?
Yeah.
It's that simple. It's that simple. So provided they're not intrusive, and the new models are not intrusive. They're quiet, they're effective, they use as much energy as a night light. We're talking about 40 watts. You can't even see it in the energy bill. So I think, and this gets to the sociology of the issue, of which I'm not. When you turn on the lights, turn on the filter. When you get in the car, you put your seatbelt on. Not everybody does it, but a lot of people do. And I think that there's a way to normalize this or provide incentives for building managers, teachers, and transportation hub managers to turn it on. And to just make that part of the checklist, the routine. When I leave at night, I turn off the lights, I turn off the filter. And Georgia just gave a really nice anecdote of that's incorporated into my daily life at home. We can make it incorporated make it easy to incorporate this in the professional life of people that manage, operate buildings, in particular teachers.
Yeah, I mean, I think the extent to which it can be part of the background maintenance so that people occupy, I will just say when people talk about like monitoring in terms of the rooms that they're in, that's just, I think that works for some, but that will not work for others. And as a mom of 2 school-age kids, just thinking about, what else I would have to check is just a little daunting. But I think that there are other approaches that can, just like we don't think about the water coming out of our taps, fortunately in this country, and other things that are in the background where we've been able to make this part of the environment in which we live. I think that there's a really compelling case to be made here. So we only have 2 minutes left. There are a few questions. I will just say, because Kenny, you mentioned a reference. I don't know that the audience can see the chat, but we will send around any references to anyone who registered for this. So just don't worry about that. We will also make a recording of this available so that people can if they miss something, be able to hear it. I'm just looking through the comments here, and I think we've covered most of them. There is a comment about, I think we talked about the pandemic being over, and don't you mean the emergency? I will just say I'm going to put my little epi hat on, which is that I talk about the pandemic being over, not that the SARS-CoV-2 virus has gone away. The virus that caused the 2009 pandemic is still very much with us, and it causes illness every flu season. So no, these pathogens don't go away, but there is still a need to deal with them, but it doesn't mean that the emergency is over. And I personally don't think continuing to call what we're in a pandemic feels feels correct from an epidemiologic standpoint. It doesn't mean that COVID isn't a problem, and it doesn't mean that we shouldn't do more, not only for infectious COVID and other infectious diseases, but as we talked about today, there's a lot of indoor air health connections that will really benefit from some of these. So I just have to say thank you to all of you, really, for lending us your expertise. Thank you for your advocacy. I know in this area in particular, it has taken a lot of hard work, passion, doggedness to get people to listen about these issues, and I'm really grateful that you have all been doing that. I'm grateful that you're willing to share with us today. This is a really an important topic today, but it will continue to be important. So hopefully we can circle back again to get some updates and to continue to talk about these issues. With that, I think we are going to end. I want to, in addition to thanking our panelists, also thank my team at the Pandemic Center who put this event together: Bentley Holt, Michael Mitchell, Leah Lovegren, and Amanda Kogan, Carly Gaskus, Marina Chalik, Andrew Gulik, Ann Wang, Alice M, and Brendan Bang. And to learn more about our work at the Pandemic Center and particularly the work around advancing healthier indoor air environments, please visit our website. There's a link there. And also there's a QR code there, which will take you to our link tree, and you can, that's a place to sign up for our webinar mailing list, catch up on past recordings, and explore other resources like our weekly Pandemic Center tracking report, which provides updates on topics like measles, flu, and other global outbreaks. As I mentioned, there's going to be a recording of this session that will be available on our events page. I think we also mail it out to attendees. And just otherwise, feel free to follow us on social media for updates. And please do reach out if you have any questions about this topic, or if you'd like to suggest topics for future webinars. And with that, we're adjourned. Be safe, be healthy, and stay engaged. Thanks all.
Thank you.